Extract 1. Questions 1 to 12.
Mr. Smithers?
That's right, Toby Smithers.
Now, I think you've been having some stomach problems.
Yes, that's right. For some time, actually.
Okay, I've got some notes here, but perhaps you can tell me in your own words about those problems. About any treatment you've been having, or anything else you can remember that seems relevant.
Okay. It all started about 9 months ago with a stomach upset.
Okay.
I thought I'd caught the vomiting bug that was going round.
Yes.
Basically, I just couldn't keep anything down. No diarrhea or anything, but it was pretty bad.
Right.
Anyway, it cleared up in a couple of days, and I went back to eating normally. The thing was, though, from that time on, whenever I had a meal, lunch or dinner, I'd feel incredibly sleepy almost before I'd finished, and for about half an hour afterwards. I didn't feel tired as such. I mean, not in the sense of fatigue. It's just that I could hardly keep my eyes open.
I see. Were you in any pain?
No, none at all. The only other symptom was that I was getting very thirsty, especially at night, so I was drinking a lot.
Right.
So I went to see the doctor, expecting some simple explanation, but she said my symptoms were quite unusual. Well, not the drinking. She explained that the stomach upset had left me dehydrated.
Yes, that's right.
But it didn't explain my other main symptom.
And the dehydration passed?
Yeah, that was just a temporary thing. Then she asked me if I'd ever had stomach cancer, which was a bit worrying.
But you haven't?
No. But then she explained that there's a condition that has similar symptoms to those I had. She didn't think I actually had that condition, because it generally affects people who've had stomach surgery, and I hadn't. It's called gastric dumping syndrome.
Oh, yes.
Anyway, what she suggested as, well, like an interim measure, was following the treatment plan for that syndrome, even though I probably hadn't got it. So I had to keep drinking, because I needed to keep my fluid levels up.
Yes.
But not whilst I was eating. So in other words, I had to separate the two activities by about half an hour. Then as for the meals themselves, she suggested an eating regime that she called little and often. So, no major blowouts and no skipping meals either.
Sure. Did that help?
Yeah, it did, but it was only meant to help me in the short term. Because meanwhile, I had various tests. I gave a urine sample, went for a blood test, neither of which showed up anything untoward. So I just hoped it'd clear up of its own accord.
But it didn't.
Well, no. The regime worked all right, but as soon as I went back to eating and drinking normally, the symptoms would come back.
Okay.
So the doctor referred me for an endoscopy. I saw a gastroenterologist for that. He'd looked at my other test results and examined me and everything.
Sure.
And of course, once the results of that came back, they showed that I'd got Helicobacter pylori.
I see.
So I went on the course of treatment, the 3 drugs for 2 weeks, 2 different antibiotics and an antacid. That's the combination which gets rid of it.
Yes.
After that, I went back for a breath test, and that was all clear. So I thought that'd be the end of it, and I'd be back to normal.
But you're not.
Well, I've given it a couple of months, but the symptoms are the same.
Okay.
If I stick to the eating regime, I'm okay. When I come off it, I'm back to square one. So I'm thinking, sure, the stomach problem that the gastroenterologist found has been dealt with, but that wasn't what was causing the original problem.
And how's this affecting your everyday life?
I mean, I can live with it. Obviously, it would be different if I was driving for a living or operating machinery, but I'm a teacher, so it's okay. But to cut a long story short, I asked for a second opinion, and so here I am.
Extract 2, questions 13 to 24. You hear a physician talking to a patient called Edward Corey. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good afternoon. Good afternoon. May I know your problem? Well, doctor, I am a patient with coronary artery disease and peripheral vascular disease with prior stent-supported angioplasty. I'm having a persistent cough for the past 2 weeks and some shortness of breath. I was also treated for pneumonia. Do you feel any chest pain, pressure, or heaviness in chest? No, doctor. What's your age? 60, doctor. Do you smoke or drink? Well, I don't drink, but I'm a regular smoker. May I know your past medical history? Well, I have coronary artery disease since 2016, peripheral vascular disease for over 10 years, chronic obstructive pulmonary disease, and hypertension. Did you undergo any surgery in the past? Yes, right fern popliteal bypass about 8 years ago, neck fusion in the remote past, stent-supported angioplasty to unknown vessel in the heart. What medications are you taking? Aspirin 81 milligrams daily, clopidogrel 75 milligrams daily, allopurinol 100 milligrams daily, levothyroxine 100 mcg a day, lisinopril 10 milligrams a day, metoprolol 25 milligrams a day, atorvastatin 10 milligrams daily. Are you allergic to any medicine? Yes, I cannot take aspirin because it is intolerant to my stomach. I get stomach upset. Okay, well, your physical examination result shows your body temperature is 97, heart rate of 90, blood pressure of 187 over 105. Cardiovascular studies show normal upstroke, distal pulse symmetrical. Heart regular with a normal S1 with normally split S2. There is an S4 at the apex. Lungs with decreased air entry. No wheezes. Echocardiogram shows mild biatrial enlargement, normal thickening of the left ventricle with mildly dilated ventricle, EF of 40%, mild mitral regurgitation, and diastolic dysfunction grade 2. Nuclear stress study shows fixed infralateral defects, no reversible ischemia identified. Laboratory data shows normal white cells, hemoglobin 11, BUN of 12.1, creatinine of 0.8, troponin of 0.04, BNP of 5700. Your premature ventricular contraction is random. You had run off 3 beats consecutive one time. The patient denied any awareness of that or syncope. Did you have any temporary loss of consciousness related to insufficient blood flow to the brain? We term it as syncope. No, doctor. Actually, I'm unaware of it. Okay, you have cardiomyopathy, ischemic exacerbation of symptoms. Electrophysiology study is required for ventricular tachycardia. Defibrillator will be determined at a later stage. Continue with metoprolol with a little higher dose of 25 milligrams twice a day. Continue atorvastatin. Increase lisinopril to 20 milligrams daily to improve blood pressure management. Take hydralazine 50 milligrams for blood pressure management. Okay, thank you, doctor.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a patient talking to a dental receptionist. Now read the question.
Hi, I'd like an urgent appointment, please.
Let's see, who's your usual dentist?
Mr. Garcia?
You say it's urgent. Are you in pain?
Yeah, it's the tooth Mr. Garcia filled last week.
Well, he's away today, I'm afraid, but there's a free slot this afternoon with his colleague, Mrs. Brown.
Well, that'd be okay, but are you saying Mr. Garcia could fit me in tomorrow?
That's right, we'd get you in first thing. Can you wait?
Well, I'm not chewing on that side and I'm taking paracetamol, which is helping. The pain started when I was eating a steak, so I'm frightened I might have upset Mr. Garcia's work. It makes sense for him to check it out.
OK, we'll book you in for tomorrow morning at 10.
Question 26. You hear part of a presentation to nursing staff about an extension to visiting hours. Now read the question.
Now, you'll have received the survey asking your opinion about extending visiting hours, and doubtless you've got your own ideas about the possible impact on your work. You're probably aware of the evidence pointing to the positive effects on patient recovery rates of increased contact with loved ones. This isn't in question, but of course things must be managed properly. I've heard concerns about how busy everyone is, that you've got enough on your plates without having to worry about extra demands from visitors. Well, we've carefully planned things to prevent you being overrun with queries, interruptions and so on. Visitors will be given a list of do's and don'ts outlining what's expected of them. Meanwhile, managers will be monitoring things carefully to make sure routines aren't disrupted at all.
Question 27. You hear a surgeon discussing a patient with a nurse in the recovery ward. Now read the question.
It looks like Mrs. Jones is still a bit groggy after her thyroidectomy. Will she be going up to the ward soon?
Yes, I'm going to call a porter. She should be going up in 15 minutes.
Okay. I've added some extra post-op pathology orders. She may have problems with the drop in her calcium. Her thyroid was just huge. We didn't see all 4 parathyroid glands, and we need to check that they haven't been affected by the procedure. She seems okay, but I want her calcium level checked twice a day. She needs to be monitored for any breathing problems, muscle cramping and numbness, and for tingling in her fingers.
Okay, I'll make sure a report to watch out for hypocalcemia is passed on.
Okay, if you need me, call me.
Question 28. You hear a chiropractor briefing a colleague about a patient called Ryan. Now read the question.
Today we're going to start with Ryan. He's 2 weeks post-surgery for a torn rotator cuff. He also had a spur on his acromion process removed. This is his first time in rehab post-surgery, I believe.
That's correct.
Okay, so today we're going to begin utilizing high-frequency vibration to break up the scar tissue forming in his left shoulder joint following the surgery. We're going to do each of his treatments that way, so you'll see a progression over time, how we get him back to a point where he's able to live his normal life. Movement's the key to rehabilitation, and this treatment resonates with the nerves too, so it should eventually help them heal quicker and reduce his discomfort.
Question 29. You hear a surgeon talking to a group of medical students about patient risk in emergency surgery. Now read the question.
If you look at the risks of elective surgery, they're really very low compared to emergencies. Clearly, then, we can make the biggest difference in reducing risk and improving outcomes in emergency surgery. Our mortality outcomes here are actually below average. We're at 8% compared to around 13% nationally. The emergency patients I handle tend to be older, so they're at higher risk. And when they come in, we haven't got long to prepare them in order to reduce any risks, maybe an hour or two. In terms of patient safety, every minute, every half hour we can use to get them ready counts. That's because the patients we're thinking about are prone to developing post-operative complications, given that they have a range of associated heart, kidney, and lung problems.
Question 30. You hear a surgeon talking to a patient who's just had a knee operation. Now read the question.
How are you feeling, Mr. Shaw?
Oh, exhausted. But the painkillers must be working. I can't feel my knee as you predicted.
You're bound to feel weary after an operation. It went well, though. We cleaned out loose cartilage from the joint. You can go home now.
Oh, thanks. I had an arthroscopy on the other knee several years ago, so I know what it's like. The idea that it gets done in less than a day is still pretty mind-boggling, though.
You'll need crutches for 2 weeks, but you should be walking okay within a month.
Oh, good.
Give it 4 months before you put any serious impact on it, though.
4 months, huh? After my last stop, I started running again within a month. Thinking about it, though, I guess I paid for it. That knee had a lot of niggles for months afterwards.
Yeah, if your body's hurting, it's telling you something.
Okay.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best, according to what you hear. Complete your answers as you listen. Now look at extract 1.
You hear a nurse called Sally Perkins giving a presentation on tetanus to a group of hospital trainees. Good morning. My name's Sally Perkins and I'm one of the registered nurses working here at the hospital. Very soon I'm going to highlight the importance of immunisation and medical treatment for tetanus infection by talking about some case reports. But first I'd like to give you a little background on the disease. Tetanus is caused by a toxin produced in bacteria found worldwide in soil, dust and manure, and it can contaminate many surfaces and substances. Because of this, the disease cannot be eradicated completely, but infection can be prevented through immunisation with tetanus toxoid containing vaccines. People who contract tetanus and recover do not have natural immunity, so they can be reinfected and therefore also need to be immunised. To be protected throughout life, the World Health Organization recommends that an individual receives 6 doses of a tetanus toxoid containing vaccine, which can be done through a routine immunisation program. Tetanus is characterised by painful muscular contractions and spasms. Involvement of the muscles of the jaw and neck has led to tetanus also being known as lockjaw. It's not directly transmitted from person to person. Instead, the bacteria enters the body through a cut or wound. The majority of patients develop the disease as a result of a deep wound or puncture, but even a tiny pinprick or scratch can be enough for the bacteria to enter the body. Although tetanus cases are much rarer than they used to be, tetanus is still a life-threatening disease because of inadequate vaccination levels and inappropriate wound care. Another major issue is that only 1/3 of people who have a tetanus-prone wound actually seek medical treatment. One of the main reasons given by people for not getting tetanus vaccine is that we already have high levels of naturally occurring antitoxin through unintentionally ingesting the tetanus bacteria in day-to-day living, granting natural immunity without ever needing a single dose of medication or vaccination. Others state that if you've potentially been exposed to tetanus, fully cleaning the wound will reduce the potential for bacteria to enter the bloodstream. The problem with these approaches is that if you've been infected and aren't aware of it, medical treatment may come too late. Now I'd like to present some case studies to illustrate the danger of taking tetanus protection for granted. First, the case of a 45-year-old woman who lives on a farm and sought medical care after experiencing leg, back and jaw pain, although she had no specific injury. Because the woman was also having difficulty breathing, doctors had to do a tracheotomy and put her on a ventilator. After 2 weeks in intensive care, the patient faced weeks of physical rehabilitation. In all, the woman was hospitalised for 6 weeks of medical care. Because the symptoms were recognised early on and because the woman hadn't completely stopped breathing, she was able to make a complete recovery. She had not received a regular tetanus booster shot and the status of her primary vaccination was unknown. The second incident I'd like to share with you occurred when a 4-year-old boy was taken by his parents to the GP with a 1-week history of general malaise, mild fever, lethargy and weight loss. He subsequently developed dysphagia, difficulties opening his mouth and dehydration. Due to the concerns about the boy's refusal of fluids, the paediatrician was consulted. The boy then began to show signs of lockjaw and muscle rigidity. Together with the lack of immunisation and a toenail infection, this finally led to the diagnosis of tetanus. The boy was then transferred to a paediatric intensive care unit for initial treatment. Initially, the frequency and severity of his muscle spasms increased during the day in ICU, but he did make a full recovery after 4 further weeks of treatment. The final case involves an otherwise healthy 53-year-old man who arrived at the emergency department of his local hospital complaining of severe stiffness in his jaw and difficulty swallowing, but without any apparent wounds or cuts. Following an exhaustive examination and attempts to alleviate his symptoms, a diagnosis of tetanus was made by the medical team. He was treated with tetanus immunoglobulin and tetanus toxoid and kept unconscious for 2 weeks. The man was discharged after spending nearly a month in hospital, including his nearly 3-week stay in the ICU, and he was not able to recall the date of his last tetanus vaccination. I'm sure you'll agree this case highlights how everyone is at risk of the disease.
Now look at Extract 2. Extract 2, questions 37 to 42.
In this part of the test, you will hear a lecture based on the subject of migraines.
You now have 90 seconds to read questions 37 to 42.
The word migraine is derived from the Greek word meaning pain in half the head, as migraine often produces a unilateral or one-sided headache. It is a common and distressing disorder, and although they are not likely to take life, migraines can destroy the quality of life. Studies have shown the incidence of migraine to be in the range of 9 to 10%. And it affects 17% of the female population and 6% of the male population. So, about 2 million Australians can expect to suffer from migraine, and that translates to 1.5 million women and about 500,000 men. It is thought that more women suffer migraine than men due to hormonal factors. There are several types of migraine, the two main types being classical migraine and common migraine. Classical migraines are preceded by an aura, the duration of which varies between 15 minutes up to almost an hour. The headache usually lasts 6 to 8 hours, although they can last up to 72 hours. Common migraines are not preceded by an aura, and the headache lasts between 4 and 72 hours and can be pulsating and unilateral. An upset stomach and vomiting are common symptoms. Migraines can be divided into a number of distinct phases. The first phase includes the early warning symptoms. A significant number of migraine sufferers experience warning symptoms for up to 24 hours before the attacks start, but may not recognize these signs unless they know what to look for. The common symptoms include changes in mood, and these moods can vary from elation, such as feeling on top of the world and full of energy, to opposite moods, such as feeling depressed and irritable. There are several abdominal symptoms common to migraine, including nausea, changes in appetite, such as intense hunger or sugar craving, constipation, and diarrhea. Neurological changes may also occur prior to the migraine, including drowsiness, incessant yawning, symptoms of dysphagia, such as difficulty in finding the right words, a reaction to excessive brightness or sound, and difficulty in eye focus. There may also be changes in behavior, such as hyperactivity, clumsiness, or lethargy. And many sufferers report muscular symptoms, such as general aches and pains. The second phase is the aura. The aura accompanies migraine attacks in about 20 to 30% of migraine sufferers. The most common aura symptoms are visual disturbances, such as bright, zigzag lines and flashing lights. As well as that, there may be difficulty in focusing or blind spots. The aura commonly affects only one eye, but it can disturb the visual field of both eyes. It usually lasts between 5 and 60 minutes, then the vision normally returns to normal. Less commonly, aura affects sensation or speech. The third phase is the headache. The headache phase can last for up to 3 days. It is often throbbing and on one side of the head, but it can affect both, and it is made worse by any kind of movement. The most common accompanying symptoms in this phase are sensitivity to light, sound, and smell. Eating can help reduce symptoms, especially starchy foods such as breads and pastas. The symptoms can be more distressing than the headache itself. The final recovery stage may last for about 24 hours, and feelings range from complete lethargy to feelings of high energy and even euphoria. Sleep often is beneficial for adults, while effective medication can improve attacks for chronic sufferers. Children seem to feel much better after vomiting, and for a few, nothing works except the headache burning itself out. The dietary triggers include alcohol, especially red wine, certain types of food, notably aged cheese or chocolate, withdrawal from caffeine or caffeinated drinks such as coffee and tea, the food additive monosodium glutamate, dehydration, and inadequate meals. Environmental triggers include bright sunlight, flickering lights, strong smells, for example, perfume, gasoline, chemicals, smoke-filled rooms, and certain food odors. Another environmental trigger is high altitudes or flying. Weather changes can be a trigger factor, as can loud noises or overuse or incorrect use of computers. Other trigger factors include the hormonal triggers. Hormonal fluctuations are implicated as a significant trigger for women as 3 times as many women suffer from migraine headaches as men. This difference being most apparent during the reproductive years. The hormonal triggers may be menstruation, and a UK study found that 50% of women are more likely to have migraine around menstruation, ovulation, use of oral contraceptives, pregnancy, and it may be worse for the first few months, but in 2/3 of women it improves in the latter part. Hormone replacement therapy and menopause.
That is the end of Part C. You now have 2 minutes to check your answers.